Hi, I'm Ishwan Rajan, Associate Professor in the section of Oral Pathology at the School of Dental Medicine. This is a talk on mucous membrane pemphigoid as part of the realms for C6 and a lab within C5. The discussion of mucous membrane pemphigoid is in the larger discussion of chronic immune-mediated and systemic autoimmune conditions or immune-mediated conditions. We will focus our discussion on mucous membrane pemphigoid, but we'll also discuss briefly how it compares and contrasts with a condition like pemphigus. Let's define what mucous membrane pemphigoid is. It's also referred to by other names, such as cicatricial pemphigoid, deriving from cicatrix or scar formation. It's also referred to as mucosal pemphigoid, given its tendency to involve multiple mucosal sites, and we'll go over those clinical features. Regardless of the sites affected, it is a chronic autoimmune condition where the body is making autoantibodies. There is an immune dysregulation where there are autoantibodies produced against certain components of the epithelium and in the setting of mucosal pemphigoid specifically against hemidesmosomes. So by definition, this is a type 2 hypersensitivity disorder where the body is making antibodies against certain components of itself. As is the case with many chronic immune-mediated conditions, this is a condition that progresses over many, many months, years, and decades in patients, and it has a tendency to have its ups and downs, flares, and periods of quiescence. Classically speaking, mucosal pemphigoid is seen in middle-aged perimenopausal women anywhere between the age of 40 to 60, 65, and tends to run a progressive course. Needless to say, men can be affected too, but the classic patient tends to be a woman. Mucosal pemphigoid, as the case with many chronic immune-mediated conditions, is a systemic autoimmune condition where you have multiple mucosal surfaces potentially involved, including the oral cavity, as we'll discuss in this module, but also, most significantly, conjunctival surfaces or the eyelid surfaces, genital surfaces, nasal mucosa, and esophageal mucosa. So by definition, mucous membrane pemphigoid is an autoantibody-mediated attack on hemidesmosomes. So where are the hemidesmosomes? Let's go back to an overall structure of the stratified squamous epithelium as we know it, and the mouse here is depicting the basement membrane, or where the basement membrane would be. This is the barrier that separates the epithelium from the underlying connective tissue. The basement membrane is not just a single sheet or a membrane that separates it. It is a very complex of proteins that separates the two tissues and serves very important functions in tethering the overlying epithelium down to the connective tissue. This is the same structure that is seen at multiple mucosal sites, including the oral mucosa, the esophagus, the conjunctival mucosa, the vaginal and vulvar mucosa, just to name a few sites. So when we think about stratified squamous epithelium, or any epithelium for that matter, there's almost always going to be, by definition, a basement membrane, because by definition all epithelial lie on a basement membrane. If you lift the epithelium away, we start to see how complex the basement membrane structure actually is. This is a structure that helps anchor the overlying epithelium to the underlying connective tissue. Let's take a look at this detailed diagram looking at the protein complexes that comprise the epithelial stromal interface. What we have down here in the blue string-like structures is the collagen 7 anchoring fibrils that tether the basement membrane down to the underlying connective tissue. Here's the basement membrane superstructure made up of a meshwork. It looks like a fishnet structure made up of collagen 4 linking proteins. And what tethers the epithelium down to the collagen 4 matrix is the hemidesmosome. The hemidesmosome is defined by a presence of numerous protein complexes, but primarily comprising of alpha-6 integrins, beta-4 integrins that forms a dimer, binding to a heterotrimer, laminin 332, also referred to as laminin 5. And together they form what we refer to as the hemidesmosome, binding to, within the cell, the BP180 and BP230 proteins, which anchor the epithelium down to the connective tissue. What we also see in this diagram is desmosomes. These are like little Velcro patches that hold epithelial cells to one another. They are junctional complexes that make sure that the epithelium doesn't fall apart. And these proteins are found not just between the basal epithelial cells, but also suprabasally between the spinous epithelial cells. They're like little double-sided Velcro patches that holds the epithelium together. This is just a very superficial look at the overall structure of the basal membrane, and as depicted in this diagram here, you have numerous little protein complexes that make up the hemidesmosome, and here's a much more detailed structure of it. You have the laminin 332 or laminin 5, alpha-6 beta-4 integrin, the bullous pemphigoid antigen 230, bullous pemphigoid antigen 180, laminin gamma 1, and each of these proteins could be a potential target for an autoantibody resulting in the disease we're going to discuss. Mucosal pemphigoid or mucous membrane pemphigoid targets specifically and for the most part the hemidesmosomes, including laminin 332, alpha-6 beta-4 integrin, and components of the bullous pemphigoid antigen complex. So what we have in terms of pathogenesis is autoantibodies directed to the alpha-6 integrin, or sometimes just the beta-4 integrin, or BP180, also referred to as bullous pemphigoid antigen 180, laminin 332, or several of the components, and this autoantibody attack triggers complement activation, and complement activation results in inflammation and destruction of the structure or the staple-like structure that holds the overlying epithelium down to the connective tissue. So what's going to happen when you have destruction of that interface is a clean subepithelial separation. And I'm going to try getting my pen functioning here. Patients are going to come in presenting with complaints that correspond to what we're going to see here. So what I'm doing with my pen here is tracing out the interface between the epithelium above and the connective tissue below. When you have an autoantibody-mediated destruction of the hemidesmosomal structures, what we see here is a clean subepithelial blister, also technically referred to as a vesicle. So this blister, marked by B, is what patients present with. They present with blood-filled blisters, or they complain that the mucosal surfaces affected tend to peel away from the underlying tissues. Obviously, this is going to result in significant discomfort, often pain, and repeated episodes result in scarring, which is why it's also sometimes referred to as cicatricial pemphigoid. This histopathological and molecular pathogenesis correspond to what we see clinically. So clinically, patients are going to present, in the oral cavity at least, with extremely erythematous, desquamative, also peeling gingiva. Patients are going to come in presenting with very red and bleeding gingiva or gum tissues, and they'll tell you, I'm unable to brush my teeth because every time I try brushing or eating crusty bread or eating something that's a little hot or spicy, the gum tissues tend to peel away completely, or they come in saying, I have blood-filled blisters in my mouth, and this can be a huge problem. What's most significant in the setting of cicatricial pemphigoid is the involvement of the conjunctiva, involvement of the lower eyelids or the upper eyelids, the palpebral surface of the conjunctiva, and the bulbar surface of the conjunctiva, with repeated episodes, forms scar tissue, resulting in little scar tags that tethers the lower lid to the bulbar surfaces that we refer to as symblepharons. That is the biggest concern that we have in patients with mucosal pemphigoid, not to mention the fact that patients with mucosal pemphigoid can have nasal involvement, genital mucosal involvement, where patients present with very uncomfortable and often painful genital mucosal lesions, esophageal involvement, where you can have painful ulcerations involving the esophagus causing difficulty swallowing, bleeding, and areas of ulceration. So here's a classic example of a patient with mucosal pemphigoid. Here's a gentleman presenting with very red gum tissues that are not typical of conventional gingivitis. This patient reports being a conscientious patient, trying to brush his teeth regularly, and he's had several dental appointments to address plaque buildup, but that is not the cause of his underlying condition. This is an immune-mediated attack on the hemidesmosomes, resulting in the findings that we see here, where the patient reports peeling away of the gingiva every time he tries brushing. And what we have in this particular area, if I could bring my pen up here again, is an area of ulceration where the gingiva has peeled away when he's tried eating or using anything abrasive in this region. So why does the gingiva look as red as it does over here? We're going to go back to the same schematic we used in our module for C5, where we think of the epithelium as lying on top of a red mattress, the red mattress corresponding to the vasculature within the stromal tissue. And the layers of epithelium above make the epithelium look nice and pink in normal tissues. When we have autoantibody destruction resulting in a subepithelial separation, you can have blood-filled blisters, the epithelium peels away. That corresponds to the erythema, where we have a raw surface or the underlying vasculature much more visible. The same process happens within conjunctival surfaces, so patients may initially report with very red erythematous palpebral or bulbar conjunctival surfaces that may present very similar to what you might see in a conjunctivitis, but this tends to be a much more prolonged process. So conjunctivitis, which tends to be much more acute, is certainly not something we should be thinking about in patients like this. They present with very red eyes, and with repeated episodes, they can present with scar tissue, as seen over here, that tethers the lower eyelid to the bulbar surfaces, resulting in what we refer to as symblepharons. This is a huge problem in patients and needs to be addressed, and one of the main reasons why we want to diagnose patients with mucosal pemphigoid fairly early on. Other mucosal sites potentially involved include the nasal mucosa. Patients may present complaining of nasal bleeding or frequent nosebleeds or bloody secretions, and examination of the nasal tissues is suggested in many of these patients because the interface between the epithelium and the connective tissue is essentially the same, and the hemidesmosomes are present almost anywhere. The same findings can be seen in the esophagus. Here on the left is a patient with a normal esophagus with a normal lumen, and on the right you have a patient with narrowed lumen resulting from repeated episodes, areas of ulceration resulting from frequent blistering, and you can see an area that looks fairly red, erythematous, resulting from peeling away of the overlying mucosal tissue. The vaginal tissues are often involved in women, and you really want to ask your patients about this, because they can certainly have areas of erythema and sloughing away of the mucosal tissue in the vaginal areas, causing significant discomfort. So going back to some of the targets, there are several antigens that can be associated with mucosal pemphigoid. When patients present with oral pemphigoid exclusively and not involving other sites, the literature shows that the alpha-6 integrin is exclusively involved, triggering complement activation restricted to the oral cavity. In patients with exclusively ocular pemphigoid, we tend to see the beta-4 integrin. When we have patients with multiple mucosal sites, which tends to be the rule rather than the exception, you have patients where you have autoantibodies directed to bullous pemphigoid antigen 180, alpha-6 integrin, beta-4 integrin, or all of them at the same time, resulting in multifocal mucosal manifestations. So here we have a condition where patients present with chronic, ulcerative, erosive clinical findings characterized by chronicity that progresses over many, many months, years, and decades, exacerbations with ups and downs in their symptoms, but also clinical presentation. And patients are going to present with foci of redness involving multiple mucosal tissues, erosions, ulcerations, vesicles or blisters, atrophy, meaning thinning of the tissues, or mucosal frigidity, where you push on the tissues and they peel away. When we see patients like this, we almost always consider a chronic immune-mediated mucocutaneous condition, of which mucosal pemphigoid is one of several. As this list depicts, mucosal pemphigoid is just one of several conditions that can present just with that clean subepithelial separation. Bullous pemphigoid is a condition that is very similar to mucosal pemphigoid, affecting some of the same antigens, but tends to be much more of a cutaneous or skin disease. And here is a list of other conditions that can look very similar, including epidermolysis bullosa acquisita, which affects collagen 7 fibrils, and some others. Let's take a quick look at a few examples of other autoimmune conditions, including bullous pemphigoid, since we just looked at mucosal pemphigoid. This tends to be primarily a cutaneous or dermatological condition. We have subepidermal bullous lesions where patients present with widespread skin blisters. You certainly can have patients with bullous pemphigoid presenting with other mucosal sites of involvement, including the pharynx, larynx, nasal mucosa, and the oral involvement in these patients is not as common as we see in mucous membrane pemphigoid. So here is the biggest concern in patients with bullous pemphigoid. There is the presence of numerous blisters on the skin. This is a fairly severe manifestation to bring home the point of what bullous pemphigoid can do when left unchecked, resulting in multiple areas of ulceration, and these patients are going to be predisposed to developing multiple cutaneous infections, so they really need to be managed aggressively. Here's a cartoon again depicting the differences between mucosal pemphigoid affecting the alpha-6-beta-4 integrin. Bullous pemphigoid antigen can also affect the alpha-6-beta-4, but primarily the bullous pemphigoid antigen 180, sometimes bullous pemphigoid antigen 230. And there's another condition, pemphigus vulgaris, that affects the desmosomal complex, which we'll discuss briefly in the next few slides. So pemphigus vulgaris, just like the others we discussed, is also an autoantibody-mediated immune condition. We have autoantibodies that don't target the hemidesmosomes. They target the desmosomal complexes that hold the epithelial cells in the suprabasal layers together. So here's a patient presenting with widespread oral involvement with very ragged, ill-defined, extremely painful oral ulcerative conditions. And on the skin, this can look very similar to what we see in bullous pemphigoid, but the blisters in this case tends to be a lot more fragile and break away, and they can cause some of the same problems that we see in bullous pemphigoid. Why does this happen? Because we have autoantibodies targeting the desmosomes. Again, these are not the hemidesmosomes that are present at the basement membrane level, but these are the junctional complexes that hold the epithelial cells together in the spinous layer. When we have autoantibodies produced against these desmosomal structures, that results in lysis of the junctional complexes, resulting in a process that we refer to as acantholysis, where the spinous layer, everything starts falling apart. They don't hold on to their neighbors anymore. That results in the ragged, ill-defined, blistering, ulcerative conditions that we see in the mouth, and also a lot of patients with cutaneous manifestations. On microscopy, it bears out where you have the basal epithelial cells still intact and tethered down to the underlying connective tissue because they're tethered thanks to the hemidesmosomes being intact. But above it, we're seeing that these cells are lifting away, and you have evidence of acantholysis in these areas. Compare that to mucosal pemphigoid, which tends to be much more, and by definition is subepithelial. So the blister in mucous membrane pemphigoid or bullous pemphigoid is below the basal layer. In pemphigus vulgaris, it is above and between the spinous epithelial cells. Very different structures. So when we do see patients with chronic multifocal ulcerative conditions that suggest a chronic immune-mediated mucocutaneous condition, we have a specific diagnostic protocol that we follow to diagnose these patients. We want to get 2 biopsies, one biopsy to look for the conventional appearance of the tissue on H&E staining. That tells you exactly where the blister is, whether it's below the basal cell or above the basal cells within the spinous layers. But you also want to get a direct immunofluorescence assay that helps you detect using immunofluorescent antibody or fluorescent tagged antibodies, determining exactly where and which autoantibodies target which structures. So direct immunofluorescence is going to help us localize whether there is IgG and complement activation in the tissues obtained and the biopsies obtained. In those patients where we're unable to get a direct immunofluorescence confirmation, we recommend indirect immunofluorescence. We have a patient's serum sent off to a lab to see if they have circulating autoantibodies. So when we suspect a condition such as lichen planus, mucosal pemphigoid, or pemphigus, we get 2 biopsies, such as in a patient like this with widespread oral involvement and ulcerative conditions, that it has a chronic course. When we see mucosal fragility, where you're seeing this patient's gum lift off when it's blown with air, you want to get the 2 biopsies, and on direct immunofluorescence, this patient demonstrated the presence of IgG and C3 in the basement membrane zone that corresponds to where the hemidesmosomes are, this is diagnostic for mucous membrane pemphigoid. Again, this is what we would see in this patient. Positivity for IgG deposition, C3 deposition in the basement membrane zone, and it's negative for some of the other Igs that that are sometimes associated with other autoimmune conditions. So again, to wrap up our talk, we think about mucous membrane pemphigoid. We think of a group of chronic mucosal blistering disorders, and by definition, it's a result of autoantibody-mediated attack on hemidesmosomes. Thank you.